A very good evening to all the participants and my fellow colleagues and professionals to Rehabilitation Science Group and today's presentation on functional electrical stimulation. Today, as a second part of the series of functional electrical stimulation lectures, we will be discussing about the methods of using functional electrical stimulation and the mechanism that are responsible for uh, assuming the recovery in stroke patients. And if you have missed the first part of the lecture, you can check the link mentioned on the screen in which we had discussed about the system of functional electrical stimulation as well as the stimulation parameters and how the electrical currents interact with the physiological systems of the human body and especially the nervous system. How electrical stimulation affect not only the peripheral but also the central nervous system. So an electrical current as minimum in millivolts or milliamperes given to the most distal periphery or extremity of the human body can have an effect on the most central aspect of the nervous system, and that is the brain. And based on the same premise is the functional electrical stimulation. Now, let us look more on how we can modify the stimulation characteristics depending on the patient requirements and various impairments, especially to the population or people with stroke for rehabilitation. And why do we discuss it? Is the fact that we all know that recovery after stroke many times is incomplete. And the rehabilitation phase and the process of rehabilitation becomes too lengthy. And many a times that despite the rehabilitation, a lot of patients do not regain 100% functionality. And it is seen that after weeks and sometimes months and even years, that there is lingering disability due to persisting impairments in the arm, the leg, and other systems or after a stroke. So, uh, so I think conventional rehabilitation has been addressing these impairments, this problem since very long. And despite the best efforts, I think some part of disability persists and stays on with the patient for quite long. And to mitigate those problems, we need a lot more to think on in terms of advances in rehabilitation. And one such advance is the functional electrical stimulation. So, generally, what happens is as a rehabilitation professionals, we look at the whole individual. After stroke, we are discussing not only about the weakness and not only about the loss of range of motion, but on the overall social responsibility and participation of the patient. And what leads to that are the impairments after stroke. So whenever a person suffers from a stroke, there are multiple systemic impairments, not limited only to the sensory and the motor system, but also the behavioral, emotional, cognitive, visual, auditory, and the thing is that in stroke, depending on the lesion, depending on the individual himself, these impairments may present variably and may disproportionately affect one individual more than the other. So, for example, the loss of dominant hand can have more disability than the impairment in the non-dominant hand. So something like that. And talking about leading to impairments, a lot of times these sensory motor impairments lead to decline in the output. That is, the patient stops using the extremities for function due to weakness, due to loss of sensation, due to lack of planning for action, or you can say just by habitually they stop using the extremities after impairments. And a lot of times the movement that the human body produces is also used for interacting with the environment. So whenever we are moving, there are two aspects to it. One is the motor aspect and the other is the sensory aspect. That is, uh, what information we get while moving, what is the consequence of a movement, what change does it bring in our surroundings. So we are always trying to get that information visually, auditorily, or by touch, or other sensations, and also by achieving the motive of the movement. And once the patient stops moving, he is deprived of all this information from the affected extremities. And what it does is it leads to a modification or shrinking of cortical representation of these weak, or you can say the affected parts of the body, because they were not used. And with time, with a decreased cortical representation, that is the area within the brain represented by that body part becomes less. And as the time progresses, with less and less use, the area starts getting lesser and lesser. And once the representation is low, that means the body part or the extremity will be used even less frequently. That is, rarely that body part will be used. Uh, in stroke, a lot of times, what we see as the major disturbances, the major impairments in the sensory motor function are the weakness. And the motor weakness can be either partial, sometimes patients are capable of partially moving, and sometimes they are completely paralyzed. And a lot of times there are tonal changes, uh, hypertonicity, hypotonicity, and the presence of involuntary movements. But a lot of times, for a therapist, it is the presence of compensatory adjusted movements that the patient assumes and learns due to the weakness in the extremity. Like in a patient with left-sided weakness, the patient starts using the right hand for everything and compensates for the deficits. So this becomes a learned phenomena to be not using the affected extremity. So this becomes a bigger problem than the actual weakness that the patient had, because the brain changes, and with time recovery does come, but the patient does not use the extremity despite the internal recovery in the systems. Looking at the sensory disturbances, patients might have primary deficits of sensation. Patients may have central or peripheral musculoskeletal pains. They may present with visual deficits, perceptual and attentional deficits, and a lot of times, due to cognitive problems, the patients do not get that motor planning or ideation to move right. So their volition to move, intention to move is also sometimes affected. So all these impairments, especially in patients with head injury and stroke, can lead to impairments in the secondary impairments in the central as well as the peripheral nervous system. So based on the patient's characteristics, that is, what is the severity, depending on what outcome do we expect from the patient. That is, do I expect a movement to become better? For example, hand, I want the patient to open hand much better. I want the patient to get better external rotation. Or is it the function that I want to him to be better at, reaching and grasping, manipulating objects, or is it the ADLs like dressing, self-care, bathing? So what outcomes do I expect from the intervention also matter in the type of uh, therapy or intervention that I use. Ultimately, it also depends upon the duration of the onset, from the onset of the disease, like how chronic is the problem. Many times what happens is, early after stroke, there is a lot of potential for recovery, and as the days, the months pass by, the recovery potential starts to decrease or reduces. So it depends on what stage the patient is, and what type of motor learning can happen in the patient. So depending on that, we can select the duration of the treatment, the intensity of the stimulation, the method of treatment, depending on the impairments, depending on the severity, and the feedback method that we will use in our patients. So there are a lot of rehabilitation models and conventional exercises, various methods and approaches to exercises are already being used in terms of rehabilitation, wherein electrical stimulation works as an adjunct to all those exercises. But due to lack of evidence and improper results and effectiveness, it is not very popular to use in patients with stroke. And why is that? Is because electrical stimulation in our everyday rehabilitation protocol assumes that the patient is passive, or the patient is not doing anything, whereas the electrical stimulation works on the body part or the muscle or the movement. So what happens is, the patient is not involved in the movement, and by the meaning of not involved is, the patient does not place voluntary effort in producing a movement, because now the movement is substituted by an external electrical current. So there is no problem solving, there is no feedback. And as such, when you see a movement happening due to an external stimulus, there is no goal, there is no skill required. So these all factors have been highlighted in research, that uh, the effectiveness of electrical stimulation was questioned, and that could be the reason that that electrical stimulation in rehabilitation could not achieve the level of effects that were expected based on the effect it creates in the peripheral and the central nervous system. Now, the thing that was lacking in electrical stimulation used for rehabilitation is that functional component of the movement while the patient was being electrically stimulated. Now, there is an importance, there is a significance of that functional aspect to that stimulation. So, an external current depolarizing certain motor units and producing a movement could have peripheral effects within the muscle, and to create learning effects within the nervous system, wherein a lot of changes happen at the level of the central nervous system in the spinal cord and the brain, within the cerebellum, then this learning needs a functional component to the movement, so which requires repetitive practice of goal directed functional movements, that requires motor planning from the patient, that requires control, that requires cognition, as well as provides a feedback in terms of visual, tactile, and proprioceptive inputs reaching the central nervous system. So, whenever there is an intention to move, whenever a volitional effort is generated by the central nervous system, it expects a feedback, it expects an input. So, that input happens when you are using the limb in a functional manner. So it is always better that we use electrical stimulation coincidentally with the voluntary drive. Now, I would like to show you a video here, and you would see that the patient uses, or the machine is stimulating uh, the limb, and what you see is opening and closing of the hand. Right. So what we see is that the stimulation does open and close the hand, but what happens is, even though it is repetitive, there is no intention, or there is no functional environment that the patient uh, is using the body part in. So a lot of times that learning effect may or may not happen without the feedback or the natural consequence of opening or closing of the hand. So, based on this, the terminology of using electrical currents mentions certain currents as like cyclic neuromuscular stimulation, in which there is repetitive stimulation of certain muscles, there is repetitive production of certain movements by external application of electrical currents, and that repetitive on and off, that is repetitive contraction and relaxation of a muscle. This happens by adjusted stimulation parameters within the machine, within the equipment, and this may have no control from the side of the patient. So, for example, a 10 seconds current with a 20-second relaxation period. So, 10 seconds on, 20 seconds off stimulation, and this repeats for a period of 20 to 30 minutes or 40 minutes cyclically, repetitively. It is not important that the patient participates in the movement. So there, it does not require the simultaneous effort, volitional effort or participation from the patient. So not very important for functional training. Uh, it, it has been shown that it has beneficial effects for patients with already having some residual use. So patients who are already using their extremity in some ways, for them it might be beneficial. So we know that the change is possible, and there is a potential for plasticity within the nervous system, the potential to change and recover, known as neuroplasticity. But that depends on the input that the patient receives during therapy. And within that, repetitive task practice has been shown to be an important aspect of bringing out that change. So, what we are talking is repetitive, that is multiple repetitions, which is already provided by that cyclic method, that repetitive stimulation and relaxation, but there is no task practice. And the characteristics of those tasks is that there the patient has to involve or have an active or a volitional effort during that stimulation. There has to be a level of challenge, and there has to be a progression depending on the state of the patient. So despite providing repetitive stimulation and lacking in that volitional or active effort, lacking that functional content within that therapy, there could be that the effects or the potential for plasticity could not be achieved until the patient participates in that therapy. Uh, so after cyclic functional stimulation, we have another type of stimulation known as switch triggered stimulation or the functional electrical stimulation. In this, the timing of stimulation can be controlled. So it is not pre-programmed within the machine. It can be controlled by a switch, an external switch which is self-initiated. So that means whenever the patient is ready to function, whenever the patient or the person is ready to move, that person can switch on the stimulation, and a pre-programmed input of electrical currents uh, initiates muscular contraction and the action produced. Uh, Very important that the patient or the person can initiate the movement with the volitional effort. What the person cannot change is the stimulation characteristics or the parameter. Like, uh, I want to grasp hard or I want to grasp light. Those stimulation parameters are pre programmed. Once set and the switch is on, it produces that pre programmed stimulation characteristics, which later cannot be changed. So some part became interactive, initiated by the patient, but another part of aspect of the treatment characteristics remained still out of control of the patient to change or modify uh, within or during the movement. So the intensity and the tasks were pre-programmed. So based on that, and looking at the drawbacks of such type of stimulation, there were developments in the currents, the use of currents, and one of it was the EMG triggered functional stimulation. Now, what this does is the EMG triggered functional stimulation detects an activity within the muscle. Now, how much activity should happen within the muscle can be decided and can be pre selected, that the patient always reaches a threshold level of contraction. After that, the remaining contraction, which the patient or the person cannot complete, is taken over by the machine. So, if I can move my body part to some degree, but the contraction is not the contraction cannot be completed, or the contraction is not sufficient to produce the whole task, the remaining task is taken over by the external stimulation. So what happens is, any electrical signal that is detected by the machine triggers the remaining stimulation of the same muscle. So, in simple terms, it amplifies the weak muscular contraction. It augments the already present muscular contraction. So, what it excludes is the patients who are severely disabled and are not able to produce even a minimal contraction. So such patients cannot use this EMG triggered electrical stimulation. But because it coincides with the voluntary effort, and there is a component of A simultaneous voluntary effort and the use of stimulation, that creates that task practice type, repetitive task practice type of uh, character to the treatment, that gives that character to the treatment. Therefore, better than the cyclic, better than in some patients, better than the switch triggered. And what happens is, the switch triggered the electrical currents which were pre-programmed. In the EMG triggered, there is a pre-programmed set stimulation parameters which triggers the contraction after that detection of EMG activity, which still could not be changed by the patient during the task or could not be modified. So, based on that, EMG proportional control type of functional stimulators are now available. And what it does is not only triggering, not only initiating the stimulation, but also the intensity and duration of the current, that is the stimulation characteristics, can be controlled by the patient. And this is much better for functional training than just the EMG triggered. So the repetitive movements are initiated based on the efforts of the patient. Some studies and researchers also mention that whenever patient is made to produce an effort, like in this EMG triggered stimulation, or like the encouraging the patient to voluntarily activate with stimulation, sometimes that effort may induce spasticity. So whenever the patient produces an effort, it may induce that spasticity. So we have to look for that and reduce the amount of effort that the patient uses during that stimulation. Another way of reducing that effort is that if the sensor is placed on the contralateral side or the non-affected side, where the effort produced by the contralateral or the unaffected side produces a contraction in the affected side. So the switch becomes the EMG action detection within the contralateral side muscles, so that effort will not increase any tone or spasticity. Lastly, there have been more advances, and one of them is the brain computer interface, or the BCI activated FES therapy. Again, this is non-invasive, and what it does is, whenever patient tries to move, whenever patient tries to do a particularly pre-selected movement or a function, it detects neural activity on the brain. So whenever that patient tries to do voluntarily that activity, as a part of that meaningful output, uh, the machine detects that neural activity and produces the stimulation through the FES. So the brain interface is detecting the neural activity in the brain at the scalp. And once it detects that neural activity, it sends a signal to the functional electrical stimulation machine to produce the movement. What it does is, the volitional effort or the intention to move is detected at the level of the brain, and the peripheral stimulation is done by the functional electrical stimulation. So in a way, we are bypassing the whole nervous system externally, and in this, the person has to learn to modify that neural activity. That means encouraged to produce that reliable and repetitive neural activity, so that the same movement is occurring repetitively by the use of the brain signals. This has led to activity dependent neuroplasticity and better functional motor recovery. The common indications that the functional stimulation is used in persons with stroke are like lack of muscle strength, for inhibiting spasticity in the antagonistic muscles, correcting contractures to facilitate voluntary motor control, and in more severe patients to increase the passive range of movements. Very important aspect of using functional electrical stimulation is to minimize compensatory strategies. Now, why do patients compensate with abnormal patterns of movement is because the prime movers do not have adequate strength to produce that movement. So by functional electrical stimulation, those primary muscles are targeted to produce that function, so that the patient learns to not use uh, compensatory strategies which may be more energy consuming, which may be abnormal looking. So patient has to learn better ways of movement and to avoid learned non-use, as we had discussed earlier. So the electrical stimulation can have both peripheral and the central effects, and on the central nervous system, motor relearning and increase of cortical excitability and reorganization are the main effects that we are looking for. The modes in which the electrical stimulation can have an effect on the nervous system is by the virtue of sensory and cutaneous stimulation, by stimulating the muscle, by providing the proprioceptive feedback which comes with any natural movement, and the functional significance and consequence. So these are all the things that happen when we are using a functional electrical stimulation. So when I use a stimulation, the electrical currents do give a sensory input or activate or stimulate the sensory nerve fibers of the body part, and somehow it does reach the cortex. Uh, Also, what it does is, while stimulation at the motor level, muscles are also stimulated. Whenever a muscle is stimulated, it produces a movement, and the movement produces the proprioceptive feedback of movement, which also reaches the central nervous system. And because we are using that electrical stimulation in a functional context, there would be a functional consequence giving that significance to the movement. So for motor learning, as we all have discussed, as we have discussed previously, sensory feedback is very important, and the sensation and action are connected. So the cutaneous stimulation, the sensory stimulus that the person receives by electrically activating fibers, uh, can increase the activation of the contralateral uh, areas of primary motor sensory areas of the brain. And this sometimes, because of an increased input from the affected extremity, has been shown to increase the representation of the body parts within the cortex. Uh, it is, although that the sensory stimulation alone may not be as effective as adding it with a volitional or a motor component. That is, we should not rely a lot only on the sensory stimulation, but when complemented by the volitional effort and movement, it does have an additive effect on the cortex. Then we should also discuss about the interhemispheric competition model. Now, what it states is that normally there is a balance between the dominant and the non-dominant hemispheres, between the right and the left hemisphere. That balance is disturbed after stroke between the hemispheres. And after the cerebrovascular accident or the stroke, there is unopposed inhibition of the affected hemisphere by the unaffected hemisphere. So, this is the competition model. And to overcome this unopposed inhibition, what we have to do is we have to recreate that balance between the hemispheres. And what recreates the balance between the hemispheres is by encouraging the movement of the affected extremity. Whenever we encourage the movement of the affected extremity, it encourages the activation and rebalancing the hemispheres. And many times, bilateral therapies are also effective to invoke that disinhibition. So you can see here an example of an action of unilateral extremity versus a bilateral extremity. Thank you. For any queries and questions, you can post in the comment section of the video. Thank you.